this explainer is based on Visually Induced Dizziness, or VID, a Vestibular Physician's Deep Review of Pathophysiology, Assessment, and Rehabilitation, published by Australian Dizziness Clinics. All right, welcome to Part 5 of this explainer series. Today, we are handing you the evidence-based management playbook for visually induced dizziness. We're going to break down rehabilitation, psychology, and the very strict, and I mean strict, boundaries around pharmacology. If you've been with us through the previous parts, you know VID is an incredibly complex condition. But the absolute best news, it's highly treatable when you tackle it with the right game plan. Let's quickly run through our clinical roadmap for today. We'll be hitting the counterintuitive fix, optokinetic vestibular rehabilitation, the graded exposure ladder, psychological interventions, the rules of pharmacology, and finally, multidisciplinary care.
Section 1. The counterintuitive fix.
Okay, so to really treat VID, we actually need a complete paradigm shift. It completely challenges our usual clinical instincts. The fix is honestly brilliantly counterintuitive. Rather than calming the symptoms down, we have to gradually and deliberately expose our patients to the exact scenes they're terrified of and actively avoiding. Why? Well, because their brain has learned to over-rely on visual input. If we just mask that dizziness with medication, we're literally hitting the brakes on their central recovery. We're blunting the adaptation. To actually fix that sensory weighting, we have to force the brain to readapt, and the only way through is controlled, deliberate visual challenge. Section 2. Optokinetic vestibular rehabilitation. Now take a look at this data. This is from Pavlu's 3 randomized controlled trials, and it totally sets the gold standard. It clearly establishes that supervised optokinetic-enriched vestibular rehabilitation therapy, or VRT, is absolutely the first-line treatment. Unsupervised or just standard gaze stabilization exercises, patients plateau way too early. But when you use supervised optokinetic therapy, think full field projection screens with those rotating optic flow patterns, the results are night and day. We're talking massive reductions in visual vertigo symptom scores at 12 weeks. And the best part is, those effects actually hold strong at the 24-week mark. So what's the magic under the hood here? It's habituation. It's essentially about repeatedly exposing the patient to sub-threshold visual triggers to progressively calm down that cortical motion response. It acts almost like a software update, forcing the brain to re-weight its sensory hierarchy back toward normal vestibular and somatosensory inputs. A structured program of, say, 6 to 12 clinic sessions over a 4 to 8 week period, combined with daily home practice, leverages this exact mechanism perfectly to retrain the brain. Section 3. The graded exposure ladder.
Now, you might be wondering, how do we get this habituation without totally overwhelming the patient and scaring them away from therapy? We use a highly systematic tool. It's a graded exposure ladder, perfectly tailored to the individual. We literally build this 6-step ladder straight from the patient's own visual vertigo analog scale, or VVS. You start simple, maybe controlled clinic environments with slow-moving lines. Then you step it up, eventually reaching real-world, high-complexity environments. Think a chaotic supermarket aisle or rapidly scrolling through social media. This way, we give them enough stimulus to drive habituation, but without ever tipping them into therapeutic overwhelm.
But here is the absolute golden rule. You cannot rush the climb. Each rung on that ladder has to be practiced over and over until the patient hits a symptom score of 3 out of 10 or less, and they have to do that across 2 consecutive sessions. Only when they hit that specific habituation threshold do you give them the green light to safely move up to the next level of visual complexity. It's a slow, measured, and very deliberate climb. Section 4. Psychological interventions. All right, we absolutely have to talk about the limbic system, which is our second major pillar of care. See, when a visually complex environment triggers dizziness in a patient who already has heightened autonomic arousal, their limbic response literally amplifies the sensory signal. It's like turning the volume up to 11. That's why psychological intervention isn't just a nice-to-have, it's essential. Cognitive behavioral therapy and acceptance and commitment therapy, especially when delivered by a vestibular-aware psychologist, are complete game changers. They directly target that hypervigilance, the catastrophizing, and the intense experiential avoidance that turns VID into a chronic nightmare. So here's the huge takeaway. If your patient has a VVS score over 45, which means profound avoidance, sending them to psychology isn't a distraction. It's an evidence-based co-treatment that gives you way better symptom reduction than just VRT alone. Section 5. Pharmacology rules. Okay, consider this a massive flashing caution sign. Vestibular suppressants, things like antihistamines, benzodiazepines, and prochloroparzine, are strictly, and I mean strictly, contraindicated for managing VID. These symptom-masking balance meds might offer a quick fix, but they reduce central arousal, impair VOR plasticity, and actively sabotage the central adaptation our whole rehab strategy is built on. No way around it. Their short-term relief comes at the terrible cost of prolonged central compensation failure. If a patient walks into your clinic and they're already on chronic suppressants, you've got to step in and gradually taper them off under your strict supervision.
Now, there is a little nuance when it comes to what we can prescribe. For isolated VID, let's be clear, there is zero pharmacological fix. None. But if the VID is coexisting with persistent postural perceptual dizziness, meaning they hit all the current PPPD criteria, that's when serotonergic antidepressants like venlafaxine come into play. Just remember, they are an add-on treatment alongside VRT, definitely not a replacement. Oh, and one more thing, betahistine, it has absolutely no evidence base here, so skip it.
Section 6. Multidisciplinary care. Bringing it all together, we synthesize these independent pillars into one highly cohesive operational strategy. Think of it as the multidisciplinary triangle. The vestibular physician sets the diagnostic framing, catches comorbidities like PPPD, and manages the total VRT dose. The vestibular physiotherapist is in the trenches, actively guiding the patient up that optokinetic exposure ladder week by week. And the psychologist? They step in to manage that amplifying limbic response and smash the cycle of avoidance. For this to actually work, the whole team needs seamless communication about exactly where the patient is sitting on their trigger hierarchy.
As we wrap up, I want you to keep this critical question in the back of your mind during your assessments. Is your patient's low symptom score actually a sign of true central habituation, or is it just a mask for profound environmental avoidance? Because let's be real, a low VVS score just because a patient completely stopped going to the grocery store, that isn't getting better. That's just hiding. Remember, targeted education, showing them that deliberate visual challenge is the real cure, along with guided exposure, are absolutely your most powerful treatments. In Part 6, we are going to close things out by looking at prognosis, special populations, and some of the wild controversies this field is still trying to resolve. Until then, ask yourself, are you treating the dizziness or are you accidentally treating the avoidance? This has been an Australian Dizziness Clinics Vestibular Physician Review. Visit australiandizzinessclinics.com for the full literature review and clinical cheat sheet. See you in the final part.